rheumatologist from Fort Collins, and I'm pleased to be here today to talk about scleroderma. You know, when they gave me the title Scleroderma 101, it reminded me of when I was in college. And I remember as a freshman, you take classes that were the 101, and you thought they were easy. And you went in there, and you found that often those are some of the tougher classes you took through your whole college experience. But today, my goal will be to kind of go through scleroderma and to talk about the different types of scleroderma and the different sorts of problems that can develop in some of the treatments. And I know that many of you are very, very knowledgeable on scleroderma, and hopefully this will reinforce what you know and maybe add a little bit more to it. And for those of you who don't know much about scleroderma, hopefully it'll be very, very helpful. So, you know, scleroderma is a complex disease, as you folks all know. It's not easy to diagnose even. I suspect most of you, before you were diagnosed, it took a fair length of time, I'm going to guess. And often before you're diagnosed, you might have been diagnosed with something else. Maybe rheumatoid arthritis, maybe lupus, maybe an undifferentiated connective tissue disease, but probably there were some other diagnoses that were thrown out there. So it's not that easy to diagnose. When you look at scleroderma, there really are three parts to it that I see. There's that autoimmune component that's there. And that seems to lead to other problems, including vascular problems. And for example, the Raynaud's, the circulation problems that you folks know so well is one of those factors. And then you could have similar lung problems where there's vascular component there, or kidney problems from a vascular standpoint. And then the last component is the fibrotic component, where you get that abnormal deposition of the collagen protein. And again, you can see it, particularly in the hands, also in the face, other parts of your body. So there's those three parts, the autoimmunity, the vascular part, and the fibrotic part. And they all kind of come together to cause the manifestations. When you look at scleroderma, I've always thought, even in my career, that it's somewhat confusing when you look at the types of scleroderma that are out there. Part of the reason for the confusion, I think, is that over the years, the nomenclature or the naming has changed somewhat. So, for example, there's scleroderma and there's systemic sclerosis. And then there's this term we don't use too much anymore, CREST Syndrome, that we'll talk about a little bit. And then there's localized scleroderma and limited scleroderma. Somewhat similar sounding, and so I think it can add to the confusion. So we'll go through those first of all here. So if you look at the types of scleroderma, the two main breakdowns are localized scleroderma and systemic. And when you look under localized, we have morphia, which we'll talk about, and then there's linear scleroderma that we'll talk about as well. Okay, we'll go through both of those. And then there's systemic, there's the three that you see up on there, what we call limited cutaneous systemic sclerosis, and diffuse cutaneous systemic sclerosis, and then also the last one is systemic sclerosis without scleroderma. So there are occasionally patients who do have scleroderma but do not have the typical skin changes. So that is only occasionally seen. In those cases, you might say, how do you diagnose it? Well, patients in that group would normally present with Raynaud's type symptoms, maybe the esophageal problems with acid reflux problems, swallowing problems, maybe typical lung findings, and then we usually have those abnormal antibody studies that you probably are familiar with to some degree, like an ANA test or an anti-nuclear antibody. And some of the other antibodies look at like anti-centromere antibodies that you might have heard about, or an antibody called the SCL70 antibody. So those antibodies are seen in the vast majority of patients who do have scleroderma, would have at least one of those antibodies being positive. And in the patients without the skin involvement, again, you particularly would rely heavily on those antibody abnormalities to make the diagnosis. So we'll talk about the localized forms first here. So localized scleroderma is really limited to the skin or occasionally to some of the underlying tissues near the skin that's involved. and but does not affect you in a systemic manner. The one thing to mention is localized scleroderma is actually a lot more common than the systemic form. Very often develops in children as a common area where you can see it. And I've got some pictures in a minute here. But it does not, this is a totally different process. It does not progress. You can't start off with localized scleroderma and end up with the systemic form, okay? They're separate sort of problems. Even though sometimes, and some of you have probably had this, sometimes we will do a skin biopsy to help diagnose too. And I'm going to guess that there's people in the audience who had a skin biopsy maybe when you first came in. And if you look at under a skin biopsy, the localized form on a biopsy will look the same as the systemic form. But again, looking at it, physically examining somebody, it's totally different. And this definitely can improve over time. Over several years, often the lesions will fade. They may not regress entirely, but they will usually fade. Sometimes they can come back a little bit and be a little more active over time. So morphia is localized patches of scleroderma, very typically on the torso, the chest, the abdomen, the back. And again, it says there, you may have one patch, you may have multiple patches, okay? And you may have a generalized form as well that could spread to larger areas of the body, but again, typically in more of a systemic scleroderma, you're having involvement of the extremities, or often what they'll come in with. This is more hitting the torso area. And so this is a pretty good photo of a patient with it. You can see that from the back. I hope it shows it pretty well. But this would be on the back, and you see it kind of sometimes has almost a waxy sort of a color to it. And it would be kind of indurated or somewhat firm if you notice that. And as I said earlier, sometimes over a long period of time, over several years, it can regress. So we said generally over 3 to 5 years, it can fade out. But you still may be left with some residual, maybe some skin darkening in that area of involvement. And sometimes the skin, the muscle tissue underneath it may have been affected in that local area. So no systemic sorts of problems. Now, another form of localized scleroderma is called linear scleroderma. And I'll show you a photo in a minute. But there's a single line or band of thickened or abnormally colored skin that will be present. It can be down an extremity or it can be on the face. If it's on the face, and I'll show you a photo in a second, often the tissues underneath of the skin are affected. And sometimes even so there's some neurologic involvement in those cases. So there's an involvement. I mean, usually often you see this in younger individuals, and it can affect the development of that side of the face, and there can be some nerve involvement. Fortunately, we don't see this very often. Now, when we go to the systemic form, the skin, of course, is very prominently involved, but also you can see internal organ involvement. And we'll talk about this, but kidneys, lungs, or GI tract are very typical areas that can be involved. So in limited cutaneous systemic sclerosis, typically it starts gradually. And the skin is more limited. Generally, you're talking about from the elbows on down and the knees on down. Spares the trunk, okay? But the face can be involved, okay? With the skin thickening and tightening that you folks know well, unfortunately. Very often, you have Raynaud's phenomenon for many years before the skin changes start. That's not unusual at all. I bet if I talk with some of you, you might mention that you had the Raynaud's for 5, 10 years or more even. And the Raynaud's, just to talk about it, of course, is the abnormal spasming of the blood vessels, usually in response to cold. But sometimes stressful events can trigger it as well. And you get that, and I'll show you a picture, but you get that which white, and very blue and purple sometimes, and then very red when it comes back. But not everybody has all those 3 phases either. And as you probably know as well, most patients who have Raynaud's do not have scleroderma. There's the most common thing is just what we call primary Raynaud's, and very typically that happens in young women more than men. Very typically, like late teens, early 20s, somebody will develop it in the winter, and often I'll see them, it seems like by about March or so, March sometimes even early April, and we'll start it in December, and they live with it for a month or two, and then they saw their primary doctor. By the time they see me, it's, things are already kind of warming up, and often it's even, improved somewhat that time of year. But in the limited cutaneous systemic sclerosis, usually that Raynaud's has been present for quite a while. We'll show some pictures of telangiectasias, which are those small dilated blood vessels that you can see very often in the hand, face, sometimes inside the mouth. Upper chest is a common area. They commonly develop, and calcinosis, or soft tissue calcium deposits. For some reason, and we don't know why, it's common in the limited cutaneous systemic sclerosis. Often those calcium deposits are in the elbow region, is very common. Often they can be in the fingers as well. Sometimes they're fairly mild and not too bothersome, but sometimes they can be very, very bothersome. Uncomfortable, sometimes you can get ulcerations over those. And we're going to talk about treatment in a bit, but right now there's no definite treatment. We'll talk about treatment for other parts, but the calcium deposits are one of the hardest. And so far there's no definitive treatment for those that are in calcium nodules. GI involvement is very common, and again, most of that is esophageal reflux is the most common sort of problem with acid reflux, heartburn, swallowing problems. But you get involvement of the lower GI tract as well, where you get problems with bloating, constipation, a thing called bacterial overgrowth. We'll talk about this a bit, where you get, because of decreased motion of the GI tract from some of that fibrosis there, the normal muscles don't contract and move the food and other things in your GI tract through, and you develop different bacteria can take off and grow too much, and they can lead to the bloating, bowel pain, diarrhea. And lung involvement is not uncommon in limited cutaneous systemic sclerosis. The lung involvement often occurs late, often after you've had the disease for 10, 15, 20 years. You can develop problems with shortness of breath, sometimes leg swelling, sometimes chest pain. And most typically it's what we call pulmonary hypertension, which we'll talk about a little bit more, but that's very common after many years of the limited form of scleroderma. So, I have a question for you. So what is CREST syndrome? And there's a toothpaste out there for sure. And when you look at this, what I wanted you to get to is that the answer is D. CREST syndrome is another name for limited cutaneous systemic sclerosis, but there's a reason that it kind of has gone by the wayside. But I'll tell you in a second. And the reason is that the CREST stands for calcinosis, or the calcium deposit. R is for the Raynaud's phenomenon. S is for the sclerodactyly, we talked about the esophageal dysmotility, and the T is for telangiectasias. So that's why they came up with CREST syndrome. Part of the reason CREST syndrome is a term we don't use so much anymore is that not everybody with limited cutaneous systemic sclerosis has all of those problems. And in fact, there aren't that many patients who have every single one of those. And that's why we've kind of gotten away from that. But if you hear about CREST syndrome, they're talking about limited cutaneous systemic sclerosis. And again, it's still out there. Occasionally as doctors, we will use it, particularly when we see a patient who really has each one of those factors. And there's just a photo of as you know, with the Raynaud's phenomenon. You see the very pale fingers and as well as some cyanotic or purplish digits there as well. And there's a photo of telangiectasias that, again, are common in the palms as well. They can be multiple areas, they're often in the face as well. And you can see in this person, they definitely have scleroderma because you can see like in that middle finger on the right. Let's see if I can get this one.
Oh, yes.
I figure that out. But you can see that there's, let's see here, there are the tips, there's those digital pitting scars and previous ulcerations you can see on there. If you're over here, folks, you can see kind of down in there, I believe, is where you can really see that, because of recurrent episodes of severe Raynaud's, You can lose some of that tissue at the fingertips, unfortunately. You get the ulcerations, it can be very difficult to manage. And then you can leave some scarring there even when the ulcerations have healed. So now we're going to switch to the diffuse form of systemic sclerosis. This often comes on suddenly, quite rapidly. Again, typically people will notice that swelling, stiffness in the hand. Raynaud's will often come on at that time as well. Pain. Often you can have fatigue as well. Feels really systemically ill. And again, often in these cases, again, you may see several doctors and a diagnosis isn't made. Maybe sometimes rheumatoid arthritis is thrown out, or lupus. And, it can be difficult to diagnose sometimes early on. And internal organ damage can involve multiple areas of the heart, kidney, lungs, GI tract, and sometimes that will come on rapidly as well. Again, fatigue, weight loss, joint swelling can occur. Sometimes you'll notice what they call tendon friction rubs from inflammation on the tendons of your elbows. You can feel it. You can feel that. It feels almost like sandpaper maybe. It can that rub. Sometimes more in the wrist area, but elbows is a fairly common area that can be seen more with this diffuse form of scleroderma. And often the damage does occur over the first 3 to 5 years when it's very severe. Again, often that's where we'll see some of the kidney involvement that can be very severe, where you develop high blood pressure. In most cases, kidney blood test is elevated, urine production is decreased, and it's one of those situations where we really need to be on it early. And I know some of you have suffered from that here, and the good news is there are medicines that can really help if you get on them rapidly. And then, though, the good part here is after the first 3 to 5 years, often a stable phase develops where symptoms are less intense and skin changes that may have developed can soften and improve quite a bit. Every now and then I'll see a patient who comes into me and says, I've had scleroderma for 25 years, and I'll look at their hands and I'll say, no, you haven't, and I'm kind of joking, but it's because the skin changes have improved so much that, you can hardly tell that they have scleroderma. And sometimes it's kind of nice when I've seen a patient for a long time and you can literally see that these skin changes are improving. And it can be fun just to talk with patients about that. At that point, say, wow, look at how much better things are. Okay, so then I put another kind of a goofy question. There's no treatment for scleroderma. Of course, the answer to that one is false. Scleroderma, like most rheumatic diseases, unfortunately, we can't cure it. And that's, our goal with scleroderma, rheumatoid arthritis, lupus, whatever. But, of course, there are treatments. So sometimes I see with scleroderma, people will, sometimes even other doctors will say, well, there's no treatment for this. Well, but just like diabetes, high blood pressure, rheumatoid arthritis, we can't cure it, but we can generally manage things. So put that one to try to dispel things there. So treatment is directed at controlling symptoms and limiting damage to organs. Okay? And again, that's very similar to every other sort of disease I'm involved in treating. So we'll go down the line on some of the more common manifestations now and talk about some of the treatment. I think we'll end with some questions if you have them. So Raynaud's we talked about already, and again, it's one of the, 95% of patients with scleroderma will have it. Some people more severe than others. But so, as simple as it sounds, the first thing they're avoiding cold exposure as much as possible. And people always look at me and they say, well, that's easy to say and hard to do. And they're really correct. Particularly here in Colorado, where the weather can change on us so much, so rapidly. But it really is the cornerstone of things, though. As best you can, avoiding cold exposure. If you're going out for a walk or something, you never know how the weather's going to change around here. Having extra layers of clothing available is important. Really good gloves, but you need to keep your core temperature warm as well. If you're going to be out in the winter, a lot of people like those warming packets for hands and feet can really help. Some of my patients get those gloves that have the heating element built in. If you can find them, usually by about now they're about sold out. at most outdoor places, but those can really help. But that's kind of the foundation, because you know where I see the worst problems are where people get out in the winter and they're not quite ready for it, and you get the blood vessels spasm down. And usually it goes through that phase where the blood vessels will clamp down and it gets really pale, and then it gets cyanotic, and then you get, when the blood flow comes back, you get that redness that comes back. But sometimes in the winter, and unfortunately I suspect some of you have been through this, you get an episode, if you've been out in the cold, and the blood vessels clamp down, and they don't want to release. And that's why you can get a lot of pain. I mean, I think you folks know that better than I do. When the tissues aren't getting adequate blood supply, you get a lot of pain. And that's where we really have to work to turn around to get in one of those episodes. And there are some medicines that you can use in those cases. You can do what they call sympathetic blocks, where they'll block the sympathetic nerves that will allow blood vessels to dilate again. Sometimes they'll do those in your neck, or sometimes just in the digits themselves. And we can give you kind of high doses of other oral medications to try to dilate the blood vessels. But really trying to do your best to avoid getting that situation is critical. Not smoking, of course, staying away from secondhand smoke. From a medication standpoint, calcium channel blockers is a family of drugs that dilate small blood vessels. And again, I've got a feeling that more than one of you is taking things like nifedipine or Procardia, Norvasc, which is called amlodipine, diltiazem. There's a lot of calcium blockers, verapamil is another older one that's out there. And those are medicines that were originally used to treat high blood pressure. But they work to lower blood pressure by dilating small blood vessels, so often they can be very helpful. Some of my patients need them year-round. Other patients will just use them in the winter months. But they can really help. They work, though, by dilating small blood vessels. Sometimes they can drop your blood pressure, so that's the main side effect. Sometimes can cause some fluid retention. But those are the main drugs we use. There are other drugs you can use if the calcium channel blockers haven't worked. They're like topical nitroglycerin preparations that a lot of people will like. Sometimes they cause headaches, which is the main complaint that I can hear, but topical nitroglycerin can work for people. There are other things that if we're not seeing improvement, you can try. There's a drug called losartan or Cozart that's being used more. There are things called alpha blockers that occasionally will get used. There's a drug called Trental. It helps blood circulate a little bit better through small blood vessels that some of my patients will do well with. Dr. Collier, who probably some of you know, who used to be here for many years, he used to give people, it's niacin-containing compounds that it kind of sometimes can cause spatial flushing, and it also dilates other small blood vessel zones, so sometimes he would use that and can help. So skin treatment, I actually, when I gave a similar talk at Fort Collins a few months ago, I said, we had a real small group where we just talked about what do people like. But for the skin itself, as you know, when this disease is very active, often there's a lot of itching with it too. It can be very severe. And what I find is often patients tell me what works for them, but there's various sort of moisturizing type preparations that people like just for the skin when it's really bothering you a lot. It's just to keep it moisturized. Can help. And again, I find this kind of very individualized. In terms of the skin itself, in an early situation, particularly in an early diffuse scleroderma, sometimes we'll use medicines like methotrexate, which is an immunosuppressive drug that I suspect a number of you have taken. Sometimes some really strong immunosuppressive drugs like cellcept or cytoxan can help the skin, but those are pretty potent drugs, again, that we have to be very cautious with. Most typically, we will use those, and I'll talk in a few minutes about when we have lung disease, interstitial lung disease, and then as a byproduct, they will often help the skin. Because again, they're pretty potent drugs. So the joint pain that we see, again, there's often the joint pain inflammation, but there's also often some tendon inflammation. Physical therapy, occupational therapy can be helpful. Sometimes over-the-counter things, whether it's Tylenol, Aleve, ibuprofen can help. If those aren't working for you, you can use prescription anti-inflammatories, or what we call NSAIDs. Being cautious because they can sometimes irritate your GI tract. If those basic prescription anti-inflammatories, that's like Celebrex, prescription version of ibuprofen, Mobic, meloxicam, if those aren't working, you can use drugs like methotrexate. Again, another strong immunosuppressive drug that is used for rheumatoid arthritis often can be used. Again, often it will help the skin as well as the joints. In terms of GI problems, again, Upper GI problems involving the esophagus are the most common thing we see. Small meals, not eating too late in the day, other sort of anti-reflux measures you can do, sort of elevating the head of the vent can help. Limiting caffeine in your diet can help. Medications such as mainly anymore the proton pump inhibitors, the omeprazole, Protonics, Acifex, Nexium, those sorts of drugs can really help. And they really, when those came out, the late 80s, early 90s, whenever they came out, they really made a massive difference for people. Because if you're having bad acid reflux, as you know, that can really make life pretty miserable. Those can really help a lot. And as I said, antibiotics, if you have diarrhea, your doctor does some tests, and they say you have bacterial overgrowth from decreased motility of the GI tract, from the fibrosis that's damaged from the normal muscles, the smooth muscles in your GI tract. Antibiotics, often they'll give you cycles of antibiotics, often a week or two per month or so, and then cycle back off of them. So kidney problems, again, this most typically presents in somebody with the diffuse form of scleroderma early in the disease, okay, the first couple of years or so. And usually, you're not feeling generally well, blood pressure can be very high, you can be very anemic with it. Usually, you're going eventually to get to the hospital because you're going to feel that sick. It does not tend to occur very often in what we've got in the limited form of scleroderma. Treatment is very important to be early. Often again, you'll see also decreased urinary output. You won't be going to the restroom very often. And treatment with drugs called ACE inhibitors has really revolutionized this. Those are drugs like the oldest was captopril, but lisinopril is more commonly used, enalapril, most of them end with a pril at the end, can really help to reverse this, to help dilate the blood vessels in the kidney. But so this is one of the more worrisome developments. That's why usually, particularly if you present with as a new case of diffuse scleroderma, your doctor is usually going to be telling you, check your blood pressure regularly. Even if you're feeling well, check it usually at least 3 times a week, if not daily, to monitor. If that blood pressure is going up, call. Don't wait. So lung damage then is another area of concern. And lung damage in scleroderma can take several forms. The 2 main forms are pulmonary fibrosis, or what we call interstitial lung disease, or pulmonary hypertension. These can coexist to some degree with one another, and for these, it's not always easy to sort out. So at times I'm sending patients down to National Jewish where they do such a good job with pulmonary problems, or to the university, and if my lung doctors in Fort Collins can't help me sort it out. But both of these can present with shortness of breath, usually with exertion, you'll notice. Sometimes you can have chest pain, sometimes you can even develop what we call right-sided heart failure, where you start getting lower extremity edema. To sort these out, so pulmonary fibrosis is more the scarring in the lung tissue, okay? It's more that fibrotic aspect of scleroderma. The pulmonary hypertension is more the vascular abnormality, where the blood vessels to some degree clamp down. They can be scarring in the blood vessels themselves. To sort these out, we usually use a combination of tests. Usually you're doing things like pulmonary function tests, which I suspect probably most of you have had more than one time, where you're breathing in and out at the lung doctor's office. And they're looking at your total lung capacity and your forced vital capacity. They're taking these deep breaths in and out. They're measuring your lung volumes. In the interstitial form, usually the lung volumes are decreased. And then usually what we call the diffusion capacity, where because of some of the scarring is decreased, the oxygen just is not able to get into your bloodstream as efficiently as it should. In the pulmonary hypertension, usually those lung volumes look pretty good, but the diffusion capacity may be down. And this, most typically, they pick up on an echocardiogram, which you probably had an ultrasound test of the heart, where they see that the pressures on the right side of the heart, which is pumping unoxygenated blood to your lungs to get oxygen again, it's that right side is working as elevated pressures, and so that it enlarges, it's dilated. And often if on an echo test they see an abnormality on that, they usually will be saying you need a right heart cath. The cardiologist has to help out. And that gives you the most accurate measure of this. Now, one of the exciting things with lung disease and scleroderma is there actually are many more treatments that have been developed in the last 10 to 15 years. Particularly for the pulmonary hypertension, which, as I said earlier, tends to develop later in the course, often in that limited form of scleroderma that we see. And there are a number of newer drugs that are out there that will help dilate those blood vessels. Things like Triclear is one that is commonly used, for example. Excuse me. And for the pulmonary fibrosis, generally treatment is with immunosuppressive medicines. Things like cytoxan or cellcept. Cytoxan is cyclophosphamide is the other name for that, which is a strong chemotherapy drug. And then, like I said, cellcept is the other one that is typically used. But it's really been exciting. I think we're getting better at monitoring early and then treating. And so most of most of the time, particularly early on, the first several years of the disease, we're usually recommending you get those breathing tests and the echo tests yearly. And sometimes if you have the disease for much longer, we don't do it every single year, and more people's insurances, your co-payment's going up so high now, people are feeling great, you just don't want to have it. But early on, I think it's really important to get that really every single year and be checked, even if you're feeling well. Again, later on, sometimes we'll go a little bit easier on that if you've had the disease for a longer period of time, but anyway, we definitely want to monitor for that. So I think that's all I had prepared, but I'm happy to answer questions about any of this. Yes?
I was wondering with Raynaud's if you are more susceptible to frostbite?
Did everyone hear that okay? The answer would be yes. You have to be careful because those small blood vessels in your trachea have been damaged in scleroderma, so yes. Interestingly, some people will come in who had frostbite injuries when they were young, and they'll have kind of Raynaud's type symptoms chronically because those blood vessels were damaged. Well, typically in that case, one of the tip-offs is usually sort of one finger. And then if you quiz them, they'll say, yeah, maybe when I was 12 years old, I kind of did get some frostbite there. Obviously, with the typical Raynaud's, it involves most of your fingers. But yes.
I have two more.
Oh.
What about if you have the fibrosis or the kidney, either one of those? What about kidney and lung transplants? How do those work at all? Do they get affected by the disease too? Or?
Well, a couple of things, and maybe I think Dr. Fisher's going to talk later, maybe more about the transplant aspect. But I will say the kidney involvement with scleroderma is somewhat different because unfortunately some people do go into kidney failure after that. And one of the rules with patients with scleroderma who've had kidney failures, you don't do a kidney transplant right away. Because on the positive side is it's not unusual over a year or two for the kidney function to come back, which is unusual. Most other forms of kidney failure, if you have kidney failure, you can start looking for a transplant pretty quickly. But with scleroderma, one of the nice things is you will occasionally see that patient who their kidney function, all of a sudden they're on dialysis, and their numbers are looking better and better, and eventually they're off dialysis.
Okay.
So yeah, that's a good question.
The other one was about transplant.
Okay, yes.
Go ahead.
I was wondering, sertraline has been helping my ulcers. Why does that help?
Sertraline has been helping ulcers, your ulcers in your fingertip. Yes, well, there's some evidence that these, it's called an SSRI, may help Raynaud's to dilate small blood vessels. And I do not know the exact mechanism, but it might. So that's one of the things on your list of things you can use for Raynaud's. It's kind of down on there, but it can at times. So yeah.
Yeah, it has helped. So I just wondered why.
Yeah, it affects serotonin reuptake, and I've never heard the mechanism. I'm sorry on that one. But.
Okay.
Yes.
I was wondering, we're doing the annual test, the breathing test and everything. Can we go to anybody that's not familiar with scleroderma, or is it better to go to somebody who knows what they're looking for?
Well, so the question I think was about On the annual testing for like breathing and the echo test, can you go anywhere, or should you go to somewhere that's used, they're very familiar with scleroderma? The ideal thing would be to go to a place that really is used to looking for scleroderma type changes. And in theory, every place, the machinery should be as good, and people who interpret should be as good, but the reality is it isn't always the case. So I think if you go to, any of the major medical centers around here in Denver, I think you could get pretty darn good testing, but if you could go somewhere that's used to doing the testing, if you're seeing a rheumatologist, hopefully I'm sure they would recommend a place that would be a good place. And then one other thing I would say is often it's not a bad thing to do some of this testing at the same place serially, just in case there's any differences in the technology that they're using to measure it. But so you do have to be a little bit careful, I would say. Oh yes, I'm sorry.
Can you talk a little bit about the right side heart enlargement and what signs you look for to know when that muscle grows to the inside, which constricts the volume capacity of the right ventricular, or when it grows to the outside and it doesn't quite so much affect that volume, and different signs and symptoms you can look for early on?
Well, so I guess the question is about right-sided heart failure from pulmonary hypertension. And so usually, one of the things we like to detect is very early, where you would potentially be having pretty minimal symptoms. The typical symptoms, at the onset are shortness of breath with exertion. As things progress and you get full-blown right-sided heart failure, you're going to usually be seeing lower extremity edema develop. Sometimes you'll be having chest pain. On physical exam, you can sometimes hear some abnormalities as well that would help you make the diagnosis. And then you would pick it up generally initially on the echocardiogram test. And but the one thing on the echo test that some of you folks may have run into is the echo test itself is not perfect. It's an easy, painless test to do, but sometimes it will overestimate what's going on in terms of the pressures in the lungs or maybe the dilation of that right ventricle. So they would usually recommend that heart catheterization, which is where they go in through your groin area and will look at the pressures better. So then, and I wanted to come back to you. I didn't quite understand, you said about the internal dilation. I don't know exactly what you were alluding to on that.
Well, with the right-sided, from what I read and some of the stuff we've talked about, with the right-sided enlargement of the right side, sometimes that muscle can enlarge to the inside of the ventricular chamber, but not always.
No, yes, it could in theory, then it could decrease your ability, the dimensions of that, so you can't fill it normally. Yes, that would be something you could pick up a picture on the echo test or on the heart catheterization.
So if you're having those undiagnosed chest pains on a regular basis,
yeah,
what do you recommend to do about that? And what do you recommend? What kind of test would you recommend?
well, I would for sure you need to get in and get checked and have that echo test as a starting point. And maybe just an EKG, because you can get, scleroderma, you can get heart rhythm problems, you can even get heart attacks even, at times. And so you probably need a cardiologist, involved as well. And one of the things that's difficult about scleroderma is that you see your primary, and sometimes you see other doctors, you come to the rheumatologist, and then often we are referring you to GI doctors for help, lung doctors, cardiologists, and then you got to try to get us all working together is another difficulty with the whole situation too. But if you're having a lot of chest pain, I think you definitely need someone who should be evaluating potential cardiology to see.
She's been told a lot of times that it's more geared towards her acid reflux, the chest pain.
Yeah.
Maybe. But
Yes.
she's also getting the lower extremity
Edema, yeah. So you get sort of.
Concerns me.
Yeah, no, very concerning, absolutely. And but sometimes it is. It's all the acid reflux. And and that's where again, sometimes you need several of us doctors evaluating and working together too, which I think we're getting better at, but it's always been a challenge. So I think we Oh, I'm moving one more question.
I have a question like cracking of my fingers crack.
Yeah.
And all.
Yes.
And I try topical hand lotions. And all what that does is make my skin greasy. It's like my whole body's greasy.
Yes.
And I use a lot of new skin.
Okay.
Is there other products out, or is
There are a lot of products out there to use, and that's where sometimes I think you have to try, because that's, what I see with that is it can be very individual as to what may work best for you. And sometimes that's where I see, like at some of the support groups I've been at, we're talking across the table and people telling you, trying different things. Sometimes it's more beneficial than as a doctor, yeah, that can be very difficult.
I'm up for people's
People, yeah, so, okay.
ideas on it.
Well, thank you for having me.